This talk is about choroidal hemangioma and evidence-based approach. So we all know choroidal hemangioma is a benign or choroidal tumor, which have basically two types: circumscribed choroidal hemangioma and diffuse choroidal hemangioma. Diffuse choroidal hemangioma is usually associated with some systemic illness like Strauss-Weber syndromes, which is commonly seen. Ancillary investigation like fluorescent angiography, which is usually required for the diagnosis, where we see the early hyperfluorescence and late hypofluorescence. And you have the indocyanine green angiography, usually indicated to find out the landmark, the border dimension of the tumor. Ultrasonography is usually helpful for the tumor thickness measurement, also for retinal detachment, to find out the detachment height. And optical coherence tomography is usually indicated for the smaller lesion and for subclinical subretinal fluid to see that the fluid is there. So what are factors determining the methods for management? They depend upon the size, the location, and the extent of the tumor, the subretinal fluid, whether it's in the foveolar areas, or the height and extent of the retinal detachment, the severity of symptoms, and the potential for visual recovery. So it all depends upon these factors to go about with the management. So there are various treatment options like laser photocoagulation, transpupillary thermotherapy, photodynamic therapy, external beam radiotherapy, plaque brachytherapy, or you have got the proton beam radiotherapy. So what this transpupillary thermotherapy does is that it hits the vascular channel, and it is done under topical or the perivalvular block, and can be repeated every 3 to 4 weeks interval depending upon the fluid resolutions, and it helps in the resolution of the subretinal fluid and also regression of the tumor. So when you see the review this literature, we found that the indication that the results, the outcomes of TTT in choroidal hemangioma was found to be 40 to 50% regression of tumor was seen, and also vision improvement was found in around 55% of the cases. So it basically caused the regression of tumor and the resorption of the subretinal fluid. When we compare laser photocoagulation versus transpupillary thermotherapy, the studies from Anand et al., where 71 cases was done, where there was visual acuity stabilization in 53% of the patients, improved in the vision in around 20%, and decreased in 26%. And another study by Garcia et al., where it was found that 50% of the vision have stabilized and 50% has improved on those cases. So visual acuity wise, TTT seems to be better than laser photocoagulations. Another study from Stephen et al., where it compared between the laser photocoagulation versus the radiation therapy, where it found that brachytherapy is found to be better in visual acuity of around improved to 75% with 100% resolution of subretinal fluid. For laser photocoagulation, have visual acuity improvement to 38% and 46% resolved subretinal fluid. And when we see on the lens-sparing radiotherapy, on diffuse choroidal hemangioma, they are found to be 100% resolution of the subretinal fluid with visual acuity improvement in 2 patients, and 3 patients have visual acuity stability. Another modality that is the PDT, that is photodynamic therapy, where this cold laser beam is given to the photoactivity as systemically administered dye, that is vertiporphyrin, which you commonly use, which create a cyclate oxygen to destroy tumor vessels, and it helps in the resorption of the subretinal fluid, that is around 73 to 100%. So what are those indications? They're indicated in a small to moderately sized tumor. Tumor should be localized in posteriorly portions, and also there should be clear media and no overlying subretinal retinal detachment. Next is the ICG enhanced TTT. ICG is a chromophore with an observation peak of similar wavelength with a laser diode that is around 800 nanometer, and theoretically it has a complementary effect to TTT, and where it will reduce the power of the diode laser and also decrease the number of sessions required for the tumor regression and the subretinal fluid resorption. So in this study, where it is compared between TTT, ICG, enhanced TTT, and PDT, it has found that ICG enhanced TTT has a better visual acuity improvement as compared to the PDT, and also the damage of the ICG enhanced TTT to the normal fundal tissue significantly is smaller to the PDT, and these studies have postulated that. So there are various factors where there can be a poor prognosis leading to the poor response to the treatments, like in case of longer duration of the symptoms, previously failed treatment, lower initial visual acuity, and presence of retinoschisis. So these are the factors which has a poor response to the treatment. Coming to the case scenario, a 32-year-old male which was referred to us with a visual acuity of 624, and the laser photocoagulation has already been done from outside. This is the post 2 session of TTT where visual acuity has improved 6.9. But having said that, there was a sectoral scotoma was found in the patient's visions. Another patient with periphoveal, just near the fovea, there's a subsequent choroidal lesions, choroidal hemangioma, where vision acuity is 636, and you can see on OCT, you can see the subretinal fluid was seen. So this is after 3 sessions of transperipheral chemotherapy with vision improvement to 612, and you can see in these pictures, you can see the retinal vessels are spared. Your main target is on the choroidal tumors, choroidal lesions. Next is a juxtapapillary lesion. Choroidal lesion is here again, hemangioma, with vision 6 by 60. On OCT, you can see a subretinal fluid with detachment was seen. And this is the post-2 session of ICG enhanced CTT. The vision has improved to 612, and you can see on this OCT in this after 2 session, the fluid has drastically reduced, the macular edema has reduced, and the vision has also improved. Next, you have got a lesion with choroidal thickness larger, 4.4, with hemangioma, with inferior retinal detachment was seen. So in this case, which was subjected for plaque brachytherapy. You can show a very beautifully using a notch plaque. Vision has improved to 612, and retinal detachment has settled very well. Another case scenario where plaque brachytherapy was indicated here in this patients, vision 6 by 60 with choroidal lesion on the nasal side, tumor thickness is 2.9 millimeters. Here again, plaque brachytherapy was done, and the visual acuity has improved to 6 by 12 after 4 months, and there was retinal detachment was also resolved in these patients, and the tumor thickness also regressions. Another case where plaque brachytherapy was done here with tumor on the nasal quadrant here, and this is the post-plaque brachytherapy. Vision improved 6.9 and in a 7-month follow-ups. Another interesting case where a 10-year-old boy with diffuse choroidal hemangioma, Sturge-Weber syndrome was there. There was vision was decreased to 6 by 36. You can see a very shallow retinal detachment inferiorly and in the inferior nasal quadrant. So this patient was considered for transperipheral chemotherapy in the quadrant away from the bacular areas. This is the choroidal thickness, diffuse choroidal thickness was there, with shallow retinal detachment was there. So this is the result in 2 months post transperipheral chemotherapy. The vision has improved, and you can see the foveolar detachment which was there has resolved. Sturge-Weber with diffuse choroidal hemangioma with hand movement visual field, hand movement close to face. Here, plaque brachytherapy was done again, and so you see the 8 months post of plaque brachytherapy. The plaque was placed in the thickest quadrant of the choroidal thickness. So when we see the role of plaque brachytherapy in Sturge-Weber's diffuse choroidal hemangioma, in these studies they have found that there was nearly about 100 to 90 to 100% tumor thickness decreases, and visual acuity has improved drastically. There's some studies where the role of oral propanol in choroidal hemangioma, but in these studies we have found that there was no consistent or sustained tumor reductions in all the studies, and few pilot studies have shown that there was improvement in vision, but that was all transient. The reduction of fluid and then reduction of tumor height was all transient, and there was on the outcomes which were not reproducible in the long-term studies. Another, the role of anti-VEGF in choroidal hemangioma, which has been described, but in all the studies where the role of reduction in the exudation was only temporarily, which was found, where another PDT or laser had to be given adjuvant, there was improved vision transiently, and there was only occasional, and then also PDT and or radiotherapy need to be given in such patients, and tumor regression was also ineffective to be found in this on all the studies. Here we found that like there was no tumor regression, and then exudation of the fluid was also very transient, and also was not recommended as a monotherapy. However, it can be given along with this PDT or other radiotherapy. So in conclusion, and I'll summarize, as a patient with SMT patients, vision 6 you can just observe periodically. TDT works well for the small circumscribed choroidal hemangioma tumor thickness less than 4 millimeters with minimum overlying subretinal fluid of less than 3 millimeters. Where the lesion is juxtapapillary and parafoveal locations, PDT or ICG NSTDT may reduce risks of vision and risking choroidal complications. And plaque brachytherapy works well in the choroidal hemangioma with associated exudate retinal detachment, tumor thickness less than 6 millimeter, and on non-macular locations. And teletherapy, that is EBRT or proton beam therapy, is effective for diffuse choroidal hemangioma with large exudative retinal detachment. Thank you all for your kind attention.
Thank you, Dr. Lomi. It was very nice presentation and variety of cases you have shown to us. I just want to ask one question. For the moderate cases or the moderate size of choroidal hemangioma, is there any kind of studies you have seen or you have tried this ICG TTT plus oral propranolol? Because in cases of capillary hemangioma for the child,
Yeah,
we
in infertile
actually give
hemangioma
oral
that do works
propranolol,
well.
and for the Sturge-Weber syndrome also
Mm.
sometimes we
There are
give. But
only few pilot studies where there's which shows that it was a transient reduction of the retinal detachment or resorption of subretinal fluid. However, we have done in one of the thesis also where ICG enhanced TTT was used and compared with the normal conventional TTT, where we found that ICG enhanced TTT found to be better as compared to the number of the session which is required, and also we found the visual acuity was better in case of ICG and TTT. Yeah.
okay,
However,
thank
we have not tried along with this anti-VEGF as of now, but there are various studies where the role of anti-VEGF was not very concrete. The decision was not concrete, as there were only pilot studies, and then the effect was very transient here.
thank you so much,
Thank
ma'am.
you.
Would you
Thank
like
you.
to comment something? Please mask. This.
So, Lomi, I think you showed one case where you used TTT for a
For
foveal,
stage where
parafoveal uh, hemangioma in
in
cases
a
that
boy, young boy,
yes,
yeah,
and
yeah.
another one you chose brachytherapy that was also parafoveal.
Hmm.
How do you decide whether, like you said, you gave a broad guideline of four
Yes, yes, yes.
millimeters height, but
Hmm.
supposing it's falling in the purview of both of them, so how would
So,
you pick
so
and choose
initially,
between?
I've shown in that initial slide that depends upon the visual symptoms. How bad is your vision? That is one thing. If it is near the parafoveal areas, if the vision is good, subretinal fluid is not much, height less than 3 millimeter, I would rather consider for TTT that is more precise, because when you place a plaque brachytherapy, even if you are using notch plaque, sometimes your margin, border margin can affect the fovea. So the radiation-induced maculopathy risk is higher.
So you feel that wherever you can use TTT, you would prefer TTT over brachytherapy in
Yeah,
these
and
cases.
that's like depend upon tumor thickness and how high is the fluid. The subretinal fluid, if it is high more than 3-4 millimeters, then your TTT won't reach till the lesions. That's the indications. Yeah,
Thank you.
yeah.